بسم الله الرحمن الرحيم. طبعا انا بعتذر جدا لان انا ما اعرفش التكنيكال اللي حصل عندي ايه، لكن احنا طبعا مع الدكتوره وسام مش عارفين نشكرك ازاي يا دكتوره وسام على المجهود اللي حضرتك بتعمليه وعلى الحماس، وان حضرتك مستحملانا كده. احنا الجماعه بتوع النفرولوجي دايما مزعجين. فطبعا بنشكر الاستاذ الدكتور وسام اسماعيل، استاذ نفروباثولوجي في جامعه بني سويف، وطبعا الممثل لمصر في الاي اس ان من نفروباثولوجي. والنهارده طبعا الحلقه الخامسه، وده يعني مش عارفين نشكرك قد ايه. اتفضل يا دكتور وسام.
ميرسي جدا دكتور حسين، والنهارده هنتكلم على موضوع مهم جدا. فالنهارده I'll break the rule، هنقف عند stages and we will open يعني لو في questions أو discussions. طبعا احنا النهارده هنتكلم عن lupus nephritis، ودي يعني a very essential part of our daily work, whether nephrologists or renal pathologists. Now, lupus is considered to be a telescopic disease because it comprises a host of different antibodies and pathogenic mechanisms. And within the kidney, it's also telescopic because it affects so many compartments of the kidney. And within each compartment, it almost affects every cell in it. In the glomerulus, for example, you get lesions in the mesangium, in the endothelium, in the basement membranes, in the porocytes, as well as in the tubulointerstitial and vascular compartments. So lupus is quite a heterogeneous disease, both clinically and morphologically. And hence was the importance of standard histological criteria in order to be able to deal with this disease and that all of us can understand what we're saying. So classifying lupus nephritis is actually an ongoing story which started very early, and I'm going to take you through this story till today, and we are still classifying lupus glomerulonephritis. Who classified lupus? Almost every single association in the world classified lupus nephritis, and this gives you and underlies the importance of this disease. The original WHO classification was in 1974 and 1975. Then it was modified in 1980 and then again modified in 1995. And from 1995 till 2003, we did not have any new classification. And the workable classification was the modified WHO. But then in 2003, we had the ISN Renal Pathology Society classification of lupus, which underwent its first phase of revision in 2018. However, even before this, in 1964, Baldwin was the first one to put a basic morphological classification of lupus, which is a very useful classification. And from my point of view, I see it's very important for understanding what actually happens in lupus. So Baldwin's have described lupus as mesangial lupus nephritis, focal proliferative lupus nephritis, diffuse proliferative lupus nephritis, and membranous lupus nephritis. Membranous lupus was added only in 1977 to his original classification. In 1975, we had 5 classes. Class 1, which was minimal, 2, again, the mesangial, 3, focal, with nothing beside it, just focal, lupus nephritis. Class 4 was diffuse proliferative or membranoproliferative, a term which was dropped, and class 5 is membranous. Following in 82 up to 1995, we had the WHO classes, which went a lot of modifications. And as you can see, this was the classification. A very complicated classification, I have to say, with several subclasses. Your class 1, normal glomeruli AB, class 2, A and B, 3 has 3 classes, 4 and 5 has 4 subclasses, and then we have class 6, which is advanced sclerosing glomerulonephritis. So this was a very confusing classification, very difficult to use and very difficult to apply on everyday practice. So the problem, and plus this, it had no precise definitions of the terms they used in the classification. There was all of this unnecessary subcategorization into different subclasses. There was uncertainty about how to classify the segmental lesions, differences in different designations, confusion about most of the classes in the classification, and most important, it was never validated for reproducibility. I did explain what we mean by reproducibility before, and reproducibility between pathologists means that if I classify a biopsy as class 3, then I need another 1, 2, 3 pathologists to agree that this is class 3. If we are 4 pathologists and each one classified the same biopsy as different classes, then this is very poor reproducibility. So in 2003, and it took from 1995 to 2003, there was a new classification of lupus glomerulonephritis, and this classification was so important that it is almost a single paper in literature, which was published simultaneously in 2 major journals. And this, of course, you know, doesn't happen in publications. So it was published in the JASN and in the Kidney International at the same time. The major objective of this classification was to standardize definitions and emphasize the clinically relevant lesions and encourage uniform and reproducible reporting between centers. So what was the classification? I just want to alert you that this is the current classification to date that we still use. So we still, up till today, classify lupus glomerulonephritis according to this classification. The classification have 6 classes, and class 1 is minimal mesangial lupus glomerulonephritis. One of the important changes was changing the term of lupus nephritis into lupus glomerulonephritis, emphasizing that these classifications are only for glomerular lesions and that we do not classify the tubulointerstitial or vascular lesions with these classes. So class 1 is minimal mesangial lupus. What does it mean? It means that I have a normal glomerulus by light microscopy. So no change under light microscopy, as we've discussed before. However, by immunohistochemistry or fluorescence, you can detect minimal mesangial deposits and or electron microscopy. Now, this is an important point because lupus is the only disease where it doesn't make a difference if you're going to use the ancillary technique, if it's immuno or electron microscopy. Why is that? Because lupus hosts a lot of antibodies, so you don't really need to know which type of antibodies. It could be IgG, IgA, IgM, and C3. It could be IgG only, it could be IgG and IgA, and so on. And if we are considering a differential diagnosis of another disease without the positive serology of lupus, we will still be stuck. So it won't make a difference. Neither EM is going to help. So in every class of the classification, it's going to be the same point. You can use it either by immunohistochemistry or by electron microscopy. So this is what the definition of class 1, normal glomerulus, minimal mesangial deposits, either by immuno or by EM. What's the major change? The major change is that the term normal renal biopsy was eliminated from a classification because this is a rare situation in clinical practice. I shouldn't be doing a biopsy for a normal patient or to have a normal renal biopsy. So this is a fundamental contradiction in terms, as this is not supposed to be a manifestation of disease. Class 2 is what's considered mesangial proliferative lupus glomerulonephritis. Not mesangioproliferative, it's a mesangial proliferation of lupus glomerulonephritis. Now you get mesangial proliferation by light microscopy and mesangial deposits by immunofluorescence or by EM. So as you can see here, this is or by immunohistochemistry. This is, you can see the mesangial proliferated, a lot of nuclei and very nice brown staining, which is the positive staining in the immunoperoxidase, restricted to the mesangial areas. So this is class 2 lupus. Again, here in a trichrome, you can see the mesangial proliferation. The important point is that all the subclasses which existed in the WHO classification was cancelled because evidence-based, it proved it doesn't make a difference whether it's mild or moderate or marked mesangial proliferation. So the degree of mesangial proliferation doesn't make a difference in a disease like lupus glomerulonephritis. It makes a difference, for example, in IgA, but it doesn't make a difference in lupus. and actually it doesn't make a difference in IgA as well. So the degree of mesangial proliferation is not important. The important thing is whether I have mesangial proliferation or not. So no differences. So all the subclasses were cancelled because there is no evidence base. Because lupus is, as I said, is a telescopic disease, and you can have a whole host of antibodies deposited everywhere, we would accept minimal deposits, subepithelial deposits or subendothelial deposits within class 2. The important point to understand in lupus glomerulonephritis is that the classes are based on the dominant pattern. And the dominant pattern is determined by the dominant site of deposits. So if the dominant site, and by dominance I mean more than 50%, is mesangial, and I have just few minimal subepithelial deposits, then this is still class 2. However, if the dominant deposits are somewhere else, then plus or minus the mesangial deposits, then the class is going to make a difference. So it's okay with class 2 to find some subepithelial or subendothelial deposits, and they are actually highly suggestive of lupus if the patient serology is not conclusive. Class 3. Class 3 is focal proliferative lupus glomerulonephritis. This class is actually defined by the presence of lesions in less than 50% of the total number of glomeruli in the biopsy. So, as you can see in this picture, we have 7 glomeruli and only 3 of them is affected. So this is class 3 because this is less than 50%. The main change in this class is that the word proliferative have been added instead of just being focal. However, class 3 lupus is a heterogeneous class. It's not your classic endocapillary proliferation. It can present with a lot of, with variable morphology, but mainly segmental necrosis, segmental tuft necrosis. Class 4 is diffuse proliferative lupus glomerulonephritis. It's the same class, but when the changes involve more than 50% of the glomeruli. Now, the ISN-RPS classification have suggested that we add letters designating whether the lesion is active or is a chronic or is active and chronic by A, C, or A and C. And I'll discuss this in a few minutes. However, we also had to indicate the percentage of active and sclerotic lesions and the percentage of fibrinoid necrosis and or cellular crescents. You know, of course, that this is what guides your management, and aggressive management will depend on the presence of crescents and fibrinoid necrosis, as well that the percentage of active and sclerotic lesion would also determine the decision to manage or not, or to give aggressive treatment or not. How much activity do we have versus how much chronicity is there. Now, this class has been most controversial entity because they have offered a subclassification classifying the class into segmental or global. So we had class 4S and class 4G. And at that time, there was evidence that they differ in prognosis and that class 4S actually has a poorer prognosis than class 4G. And they are not the same continuum of the disease. However, further on and with further studies, it proved, and with larger cohort of patients, it proved that there is actually no difference between class 4S and class 4, and that the subclassification was not that important. This is an example of class 4S. As you can see, this is basically segmental lesion, segmental meaning it involves less than 50% of the glomerulus, as you can see here and here. The rest of the glomerulus is fine. However, the deposits usually noted by immunohistochemistry or fluorescence are diffuse. They are not usually segmental. While 4G means that the changes are global. The whole glomerulus is affected, as you can see here. And of course, it has to be most of the glomeruli, since by definition, to say class 4 is more than 50%. And it's mainly subendothelial deposits. This is again class 4. You can see this is 4G if we're going to follow the classification, and you can see the whole glomerulus is affected. You have a lot of cellularity. You have this very small, broken down nuclei, what we call karyophytes. Here you have extensive subendothelial deposits and hyaline thrombi. Again, a mixture of lesion, a very heterogeneous biopsy for a very heterogeneous disease, I have to say. And the heterogeneity which is noted in the biopsy is in itself raises the question of lupus, if not clinically suspected. There is hardly any other disease, systemic disease, which causes this amount of heterogeneity within a renal biopsy. As you can see, this is a glomerulus, again, with what we call endocapillary hypercellularity or proliferation and extensive subendothelial deposits and hyaline thrombi. By immuno, you get very nice deposits lining, especially with the subendothelial deposits, and you get extensive, very strong IgG. IgG is the dominant immunoglobulin you usually see in lupus, and even with the immuno, you can see that you have subendothelial and subepithelial and mesangial deposits as well. So this is class 4 lupus. You can also get segmental tuft necrosis. This is fibrinoid necrosis. And usually the necrosis is just this small area within the glomerular tuft. And of course, crescents. And crescents could be cellular or fibrocellular. This glomerulus also had necrosis. This is a trichrome stain. And by electron microscopy, you get extensive subendothelial deposits, RES bodies, which are characteristic of lupus glomerulonephritis, characteristic, not pathognomonic. And you can also get subepithelial deposits, again, a hallmark of lupus to find immune complex deposits everywhere within the glomerulus. But as you can see, the dominant deposits, all of these large, huge deposits, are mainly subendothelial. So this is class 4. Then we have class 5, which is membranous lupus glomerulonephritis. And this class is the most class which can be associated with other classes, means that the patient can have 2 classes in the same biopsy. So she can have class 5 and 2, class 5 and 3, class 5 and 4. Membranous, this is your classic membranous. However, in lupus, really the deposits are very pronounced. You almost get red basement membranes in trichrome, very nice immuno, and extensive subepithelial deposits, again with some subendothelial deposits which could be noted. So this can happen. However, in 5, the deposits does not have to be global, meaning it does not have to involve all the basement membrane. You can have just segmental subepithelial deposits, and they are still class 5 lupus. And finally, before I moved, all the subclasses which was in class 5 were also eliminated from the WHO classification because it gave undue emphasis to class 5. And a threshold for the combinations have been put. The threshold is 50%. If I have subepithelial deposits in less than 50% of the glomeruli, and the other 50% has extensive subendothelial deposits, then this is class 4. It's not 4, 5. But if the subepithelial deposits denoting that this is membranous are present in more than 50% of the glomeruli, and more than 50% also has class 4, then this is a combined class. So the threshold for combination is that every dominant class has to involve more than 50% of the glomeruli in the same biopsy. Does that mean we will count the same glomerulus for both lesions? Yes. So I'll count a glomerulus which has extensive subepithelial deposits as in class 5. And if it has extensive subendothelial deposits, I'll also count it within class 4. Anyhow, this is the problem of the pathologists, so you don't really need to get to know all the details. I'm just explaining what is the threshold for the combination. So it doesn't work if I have only 2 glomeruli with class 5 and the rest of the biopsy shows class 4. This is not 4, 5. This is only 4 because the membranous is less than 50%. And all the subclasses, all the strange subclasses or subcategorization of class 5 in WHO were removed. Because at the end of the day, the important point is what is important for the patient is the identification of activity. So you really need to emphasize and identify that the patient is active lupus rather than focus on the presence or absence of class 5. Then class 6 are the advanced sclerotic lupus glomerulonephritis, in other words, end stage. Now this class, as you can see, again, a green biopsy with a lot of globally sclerosed glomeruli, extensive interstitial fibrosis and tubular atrophy. However, this is not included in the class. The class is based on the glomerulosclerosis only. Now, this is a class which is hardly diagnosed or hardly used because its criteria is very strict and it's not actually present in daily routine work. Because this class requires that more than 90% of the glomeruli be globally sclerotic with no evidence of ongoing activity. And in real life, this does not actually happen a lot. So very rarely you get a class 6. You usually get around 80% or 85% global sclerosis, or sometimes you get a 70 or 75% global, it's just still end stage. And then you still get 1 or 2 glomeruli with still evidence, so they do not fit into class 6. And they have to be classified as class 4, mainly chronic. So, class 1 and class 2 lupus are only mesangial. So if you see in this scheme, this is our capillary loop, this is the endothelium, these are the epithelia, and this nice red cell is the mesangial cell. So in class 1, you have no mesangial cell proliferation, but you have only the deposits, these black deposits, which you can only detect either by immuno or electron microscopy. In class 2, the mesangial cells are increased. So that means that they are starting to proliferate. So we have mesangial proliferation and you have more deposits, not just the minimal deposits you see in class 1. And this is class 2. So class 1 and class 2 are restricted to the mesangial areas. This is your patient, which is going to come with some hematuria, with some proteinuria, no consumed complement, no activity, no clinical activity. What's the difference between them and between class 3 and 4? In class 3 and 4, you get not only mesangial proliferation, but you also get the endothelial cells proliferated. You also get inflammatory cells, these nice green cells, leukocytes. So you get a lot of cells at work here. The mesangium, the endothelium, and infiltrating leukocytes, so a lot of cellularity. And you also get deposits in the mesangium and in the subendothelium. So this is the differences between class 1 and class 2 and class 3 and class 4. What about the rest? 5. In pure class 5, you get mainly subepithelial deposits in the basement membrane. So you get a membranous pattern of glomerulonephritis. You get class 5 membranous. You might have some subendothelial deposits. Why not? You might have some mesangial deposits. Why not? And this tells you that you are in a secondary membranous GN, or it's a lupus membranous GN. What about class 3, 4, and 5? When you have a combined class, you have the same dominant subepithelial deposits all through the glomerular basement membrane, but not your minimal subendothelial deposit. No, you have extensive subendothelial deposits here as well, and not your few mesangial deposits. No, you get extensive mesangial deposits here as well. And the difference between this class 3, 4, plus 5 and 3 and 4 is the lack of subepithelial deposits. So as you see, the classes depends on the site of the deposits and the compartment that is affected. Lupus is the best example of what we discussed earlier as patterns of glomerulonephritis. So I consider this talk as a sum up of all what we've discussing about glomerulonephritis since we started. let's take a case. This was a 20-year-old female who presented by edema of lower limb, arthritis. Her serum creat was 2.4 and she had a proteinuria of 4.5 grams. She was ANA positive, double-stranded DNA positive, and she had a consumed C3 and C4. Anybody objecting that this is lupus nephritis or lupus glomerulonephritis?
It is lupus, yes. It's lupus nephritis.
Yes, it's lupus nephritis. Okay. Which class are we considering here? Is it 1 and 2? Is it class 3, class 4?
It is 4.
Class 5. It's 4.
Yeah.
Any other ideas?
If, yeah, in the chat, there's D. So we have D, 3 and 4, or 4. And
This is not 3 and 4. This is 3 or 4. Yes.
Okay. So it's mostly class 4, because class 4 is the most predominant, and here there is a renal impairment, so it is almost 4, maybe 3.
Okay. Exactly. That's the whole point. We do not disagree that this is an active lupus. This is a typical clinical presentation of an active lupus. Low complement, renal impairment, heavy proteinuria, everything. And we know she's lupus because she's serology positive, she ANA positive and double-stranded DNA positive. But you cannot know whether she's class 3 or 4 because this is a classification by biopsy. So she is active lupus. She can be class 3 or class 4. And as you can see, this is her biopsy. She had a full-blown crescent here. She had very nice hyaline thrombi. This is what we call hyaline thrombi. She had some endocapillary proliferation and an early crescent here as well. And another full-blown crescent with fibrinoid necrosis. Here, the fibrinoid necrosis is in the crescent, and this should not be classified as different as fibrinoid necrosis on its own. It should not be considered that the glomerulus has necrosis. There is a difference between having the necrosis in the tuft or in the crescent. In crescents, it's common to see fibrinoid necrosis, but in the tuft, this is a different pathology. Her immuno showed dense IgA, IgG, C3 everywhere, basement membrane, mesangial areas, and she had segmental GBM, IgM deposits. So she's lupus nephritis or glomerulonephritis class 4G, as we all agreed. Patient received aggressive treatment and with marked clinical improvement. She got married and had one full-term normal delivery with a healthy child. She was lost for follow-up, but she stated later that regular analyses were normal apart from some albuminuria, but this was totally non-specific and that she had no test results with her. 3 years after the first biopsy, she presented with vomiting and marked asthenia. Investigations showed proteinuria 2 grams. She had also microhematuria. She was markedly anemic, hemoglobin 6. Serum creat was 2.2. She had a very high titer of lupus markers, meaning very high double-stranded DNA, consumed C3 and C4, and a second biopsy was done. Now, what's going on? Is she in activity again? Or is she class 5? Or is she class 1 and 2? Or does she have something else in her biopsy?
So it depends upon the, I think so long as she had the normal delivery, creatinine was improved to normal before pregnancy. So and I think now we have creatinine too. I cannot say end-stage kidney disease, but it is proliferative because usually proliferative is persistent. So, and this is in the chat, class 3 or 4.
Okay,
maybe.
Great.
Okay.
Yeah, when it comes to lupus, everybody knows the answers. So she did have focal, this time she had segmental necrotizing lesions, segmental tuft necrosis, as well as small crescents, and she also has segmental sclerosis. Her biopsy showed only 20% of the glomeruli were affected, and the remaining only showed mild mesangial prominence. She had sclerotic nodules, she had mild interstitial fibrosis and tubular atrophy, and her immuno showed diffuse IgG and C3 deposits, IgA and IgM negative. So, would you diagnose her as lupus? This is a tricky question, so be careful. Okay, now, Dr. Hussein, you're muted. She is lupus nephritis class 3. And the reason I asked the question is because of the antibodies. Now, yes, lupus gives a full house pattern on immunohistochemistry, but only in textbooks. And when you are lucky, it doesn't happen in real life and not in every single biopsy. So in a lot of biopsies, you only get IgG and C3. In children, sometimes you don't get any IgG and it's IgA dominant, because in children, actually lupus has a completely different pattern. So
we have here, Dr. Wesam, 2 comments. They asking why it is not class 5. This is from the 2 of the attendees.
It has segmental tough necrosis.
Yeah.
Why would it have to? Why would it have be class? Why would it be class 5? There's no membranous pattern. It's not membranous. Class 5 is membranous. Why would it be class 5? Now, this is the pathology. This is segmental tough necrosis. It has an active lesion, which is necrosis, and it has crescents. So if we have necrosis and crescents, we cannot classify as 5. We can only classify as 3 or 4. And in all classes, you're going to get IgG and C3. So it's not, yes, they wanted to know why it's not membranous, because they counted on the fluorescence pattern. Remember, I told you, we do not diagnose by immunohistochemistry. We diagnose by light microscopy, and you confirm by the immuno. So the presence of IgG and C3 is accepted. She has to have IgG and C3 and diffuse and subendothelial and everything, because she is lupus. She's class 3 because she has fibrinoid necrosis and crescents. She again received aggressive treatment and also with clinical improvement. However, 2 years later, she presented with a slowly progressive deterioration of renal function with minimal edema and marked hypertension. Her investigation showed mild proteinuria. Her proteinuria this time was only 900. Serum creat was 4. Severe anemia with mild elevation of ESR and normal complement, and a 3rd biopsy was done. So what's the story now?
It is mostly class 4 chronic.
Yes, mostly class 4 chronic. As you can see, she had segmental sclerosis. She had some mesangial proliferation. She had no evidence of any active lesion. She had extensive interstitial fibrosis and tubular atrophy. And she had very bad blood vessels, which resulted in her hypertension. So the message here is that I just want you to know that these are classes and not stages of the disease. Patients do not pass from class 1 to class 5. This is not the way it works, or from class 1 to class 6. And they are also not grades of the disease. It doesn't mean that class 5 is worse than class 4, but of course, because all of you know that this is not true, and that the worst classes are class 3 and class 4. So this is classes and not stages of disease. Cases can jump from a lower class, she can be class 2, to a higher worst class like 3 or 4. They can jump, but they can also jump from class 5 to class 5, from class 2 without going into an active phase. Patient could be class 2, then in the next biopsy, she could be class 5. She doesn't have to go through 3 or 4. And also patients change from class 3 or 4 to class 2. So it goes always up and down because these are just classes of the disease. They are neither stages nor grades. So this is very important to know. And this is why do not base your current diagnosis of a lupus patient on an older biopsy, because we get this a lot. But she had a biopsy 3 years ago or 2 years ago or even 1 year ago, which states that she has class 4 lupus. And now she's presenting with such and such, proteinuria, renal impairment, whatsoever. And please revise the first biopsy. Why should we revise the first biopsy? We need a current biopsy because patients are not stable. This is not a single presentation and you don't get a single pathology. This is not membranous. So I diagnosed her membranous 2 years ago and then she's presenting now and she's still membranous. No, it doesn't work like this with lupus. So it's important to know what the patient had as per previous biopsies to compare with the current biopsy, but the previous biopsy is not going to tell you what your patient has now. You always have to biopsy upon different presentations. Class 3 and 4, always remember that 3 and 4 can be complicated by segmental sclerosis, which is the healing of active lesions, and persistent proteinuria, which is, of course, as you know, injuries to the tubular interstitial compartment, and that the tubular interstitial compartment is the main anchor of the renal function. So a patient with a slowly progressive rise of serum creatinine is having progressive interstitial fibrosis, and tubular interstitial lesions and vascular changes are quite important in a biopsy. Let's move to the activity and chronicity scores. First important point or important information is that activity and chronicity scores are not related to classifications. So they are not part of the classification, whatever classification of lupus, since people started to classify lupus, the classifications are separate from the activity and chronicity scores. The activity and chronicity scores were developed by different people and they are independent entities of the classification. So activity and chronicity scores, we had the SLEDI system, the BILAC system, the Pollack and Pirani, Austin Moore, etc. So there are so many systems for activity and chronicity scoring. However, the most reproducible one, if we can say that it's reproducible because it also has poor reproducibility, but the most widely used one and widely accepted and what almost every renal pathologist in the world uses is the NIH, the National Institute of Health, the British National Institute of Health, Activity and Chronicity Indices, which was developed by Pollack and Pirani. So this activity and chronicity indices have basically grouped a group of lesions they considered a sign of activity and gave them a score, and a group of lesions which they considered them significant lesions for chronicity and they gave them a score. The advantage of this was a guided management in potential lesions in the activity index. So it told you that you have crescents, that you have fibrinoid necrosis, that if you go aggressive, then patients might resolve. The disadvantages of these activity and chronicity indices was that it was a weak predictor of long-term prognosis and does not include any chronic tubular interstitial lesions, does not include any vascular lesions. And as I said, they were not very reproducible. So what are these scores? The activity score is scored over 24. What are the lesions that we score? We score cellular proliferation, not mesangial, endocapillary, endothelial proliferation, and the presence of inflammatory cells. We score fibrinoid necrosis, we score cellular crescents, we score how many glomeruli have subendothelial deposits and hyaline thrombi, we score how many glomeruli have leukocytic infiltration, and we score the extent of interstitial inflammation. And we give a score from 0 to 3 by percentage. Again, the same scoring system we've been discussing for everything. 0 absent, 1 up to 25, 2 from 25 to from 26 to 50, and 3 more than 50. So it's either scored by the area of the biopsy you have or by the number of glomeruli divided by the total number of glomeruli. So we do a lot of math actually within the biopsies scoring all of these lesions. Because fibrinoid necrosis and cellular crescents are considered the most important lesions in prognosis and in management, the score is multiplied by 2. So we score from 0 to 3. So for example, if a patient has 20% fibrinoid necrosis in her glomeruli, or 20% of her glomeruli involved by fibrinoid necrosis, then this is a score of 2. Then the final score is 4. We multiply by 2. So you get a high total score at the end out of 24, indicating the extent of activity of the patient. As you can see, subendothelial deposits, hyaline thrombi, and wire loops, as I'm going to discuss, they are all the same category because they are all the same lesion. They are a continuation of each other. So they are all scored as a single lesion of activity. Chronicity is simpler, much simpler, because we have glomerulosclerosis, again, number of globally sclerosed glomeruli, fibrous crescents, if we do, and the extent of interstitial fibrosis and tubular atrophy, like we score them where in any other disease. So this is the scoring as I said, from 1 to 3, where 0 is none, 1 less than 12, 2, 26 to 50, and 3 more than 50. The question is, which class to be scored? This is an important question, and it could be debatable as well. What makes sense, or what is logical, is that the classes to be scored are the classes where the lesions are present in order to score them. And these lesions, by definition, are basically present in class 4 and class 3, what we call active loop glomerulonephritis. These are the classes which has crescents and fibrinoid necrosis and inflammation and so on. So the class is so scoring should be applied to 3 and 4. However, this is me only, and this is my opinion. I don't score class 3 because you know very well that you treat class 3 and 4 the same way. You give them the same management. And when you come to apply this score to class 3, you will never add score 3 because class 3 by definition is less than 50%. So you will always give a very low score to a class 3 biopsy, indicating in a total score that the patient is not that active, although the patient could have 40% crescents, which is quite a very high activity. But if I applied the score, then you're going to get only a 4 out of 24.
Would I ask here a question, Dr. Wesam? If this is the situation, why in revised criteria they propose to do scoring for all
classes?
Yeah.
I'll say, yeah. Well, I don't want to complicate things, but anyhow, why they propose this? First, because the chronicity score is important. Because in any of the classes, whether we have class 2 or a class 1 or class 5, then you could have chronic changes. So chronicity scores is important. So actually, yes, chronicity scores should be applied to all classes because it gives you an idea how chronic your patient is. But on the other hand, an argument is that we already do this. We already do it in any other disease. So chronicity changes are already classified and scored in all within a biopsy report. As for the activity, Well, I think the scoring was proposed to be in all classes because of the other deposits. In class 2, sometimes you get significant subendothelial deposits, just subendothelial deposits, and you don't know what to do with it. Are they significant or not? We don't know. Same in class 5. You get sometimes extensive subendothelial deposits and you don't know whether to classify them or not. So this was just a proposal to add a percentage of activity to each class, alerting the clinician that maybe you have an early class 3 or 4, which is going to happen. We already know that. We already see that we have subendothelial deposits, mainly in class 2 and 5, and their significance have never been properly evaluated. So it was just a proposal in this in the revised classification, but they still have to work on it. So this is not final. They need very strong evidence base in order to really score each class of the of lupus. But that's the base behind it. That it gives you an idea whether you have any form of limited activity, and it should give you an idea about the chronicity which is in the biopsy. Okay?
Okay.
Good.
So still,
Before
excuse me, so still the revised criteria is in the working process and not final.
Yes, we will come to that. Yes, yes. No,
okay,
nothing is final.
Okay,
we will come to it.
So you'll discuss it. Okay.
Yes, of course.
Okay.
Yes,
okay.
of course. Okay. So before this new classification, there was other trials to make a proper, more significant biopsy index for activity and chronicity. And I do sincerely hope we don't end up one day with one of these chronicity and activity scores, extremely complicated, as you can see, so many items, not practical at all. The more you complicate the scoring systems, the more they are going to be. Of course, this complicated scoring system had a very good prognostic significance because you scored everything, but it was not reproducible and nobody actually used it. So the problems with the activity and chronicity scoring actually was lack of national and international consensus, lack of inter-observer reproducibility, and the important point here is that what I would score as karyorrhexis, others are going to score it as neutrophils. It seems to be less important in children. It doesn't really reflect or does not have the same strong prognostic or management indication like in adults. And it ignores very important factors. It ignores vascular lesions like thrombosis and thrombotic microangiopathy, which is a very important factor. It ignores C1q if we're doing C1q. It ignores, again, glomerular, the presence of glomerular macrophages and monocytes, and we've been alluding to this, and we will mention it again, that actually monocytes are the main drivers for glomerular inflammation in any glomerulonephritis. So they are important to be recognized and identified, and the interstitial involvement is not given enough weight, although this is actually what's going to be reflected on the patient's function. So in order to try, in 2003, they have tried to overcome the problems with the chronicity and activity scores. So they tried to make it simple and said that they're going to use letters A for any feature of activity and C for any feature of chronicity, whether it's segmental or globally sclerosed. And A and C if you have the same, you have both. You have active and chronic lesions. يعني إيه الكلام ده? Look at this glomerulus. This is a trichrome stain. And trichrome, as much as it stains nicely, very nicely, the fibrosis, it also stains very nicely the fibrinoid necrosis. So this is fibrinoid necrosis, which is that nice pink, and this is sclerosis, and this is necrosis, and this is the rest of the glomerulus, which is normal. It has nothing else. This is typical vasculitic lesions, not only lupus. This is a typical vasculitis because, you know, vasculitis comes in episodes. So you have evidence of an old episode of vasculitis, which is segmental sclerosis, and you have evidence of a new flare of the vasculitis, which is the fibrinoid necrosis, and in the same glomerulus. So this is the glomerulus, which would be scored as A and C. So this is what is meant by an active lesion, which is fibrinoid necrosis, and a chronic lesion, which is segmental sclerosis. Again, this is one glomerulus, and you have here a crescent. This is PS, so this is why crescents are faintly stained. And you have here a lot of inflammation, and you have here a nice wire loop lesion. Again, the crescent, again, inflammation, and you have here sclerosis, a segmental sclerosis. So again, a glomerulus with active lesion and with chronic lesions. So this is a C, or active and chronic. So this is what we mean by active and chronic. And this is what I meant by that in lupus, we count the same glomerulus twice. So this glomerulus is going to be counted when I'm scoring the activity, and it's going to be counted again when I'm scoring the chronicity. And they have proposed a more adequate or a more clear definition of what's considered active and chronic glomerular lesions. So the classification have identified active lesions as endocapillary proliferation with or without neutrophils, karyorrhexis, which is nuclear dust with no further identification, fibrinoid necrosis, crescent, cellular or fibrocellular, subendothelial deposits, which simply equal wire loops. Here they separated the hyaline thrombi and gave it a separate weight and removed the interstitial inflammation. In chronic lesions, they identified glomerular sclerosis, fibrous adhesions, fibrous crescents, and interstitial fibrosis. Why did they remove it from the active lesions? Because they made a recommendation that a diagnostic line of the report should include entries for tubulointerstitial and vascular lesions, like the extent of interstitial fibrosis versus inflammation, and all forms of arterial or vascular involvement, and to give separate diagnoses for other pathological processes. Now, lupus is not only glomerular. Lupus produces tubulointerstitial lesions, and in very rare entities, active lupus glomerulonephritis can come purely tubulointerstitial. Tubulointerstitial lesions, mainly interstitial inflammation and fibrosis, may be encountered in all classes, as I've just mentioned. Inflammation, however, is an important indicator to where you're standing, because inflammation is very common in proliferative classes, like class 4 and class 3, and one of the main reasons why you get renal impairment. It's present to a lesser extent in class 5, and it's very minimal really in class 2 and class 1. So it's a nice element to use if you have an inadequate biopsy or a biopsy with a small number of glomeruli, and all what you're seeing is mesangial proliferation, for example, or you're seeing normal glomeruli, but you have a lot of interstitial inflammation. This should alert the pathologist that you probably have activity which is unsampled, which was unrepresented in this biopsy, because the frequent thing is, or the common is that you have this extensive interstitial inflammation in class 4 and 3. Of course, in all cases, you have to comment on the extent of interstitial fibrosis and tubular atrophy. Example, interstitial inflammation in class 4, you can see you get extensive interstitial inflammation, and you also get tubular injury, edema, and all types of cells, again, not neutrophils, because neutrophils will indicate a form of bacterial infection. Later on, studies have came to check the relation of tubulointerstitial lesions to the lupus glomerulonephritis classification, And as I was just mentioning, that in this study where they studied 313 patients and they scored the tubular interstitial inflammation and tubular atrophy and interstitial fibrosis, and as you can see, the most severe or pronounced tubular interstitial lesions were noted in class 4. More than 50% of the cases of class 4 had a tubular interstitial. So actually, tubular interstitial affection would go hand in hand with the glomerular affection, according to this study. However, another study did not show that the severity that it correlates. They showed a poor correlation of degree of tubular interstitial disease and glomerular lesions, and this is when they've done a univariate analysis by CD45. But the important points are the tubular interstitial inflammation will lead to increased creatinine and decreased GFR. And eventually, this tubular interstitial inflammation will lead to tubular interstitial scarring, which is going to worsen the renal functions and decrease glomerular filtration rate. The severity of the interstitial nephritis, not the lupus nephritis, is what predicts the renal survival. Again, it's the severity of the tubular interstitial lesions is what's going to tell you the prognosis of your patient, not the class. And the prognostic utility, why the NIH chronicity score is considered reproducible in prognosis, because it gives a very high score for tubular interstitial scoring. This is why the chronic score is much more reproducible than the acute scoring system. Not only glomerular, not only tubular interstitial, but vascular. Vascular is extremely important in lupus. This is vasculitis. This is basically a vascular disease. So all lupus patients are hypertension, and it seems to be underestimated. By the way, your patients complicate because of their hypertension rather than the lupus. So you get arteriosclerosis, and arteriolosclerosis are common. You can get uncomplicated vascular immune deposits, which are simply immunoglobulins deposited in the arteries or arterioles. You get a lesion known as non-inflammatory necrotizing vasculopathy, which is also called lupus vasculopathy. You get thrombotic microangiopathy, whether the patient has antiphospholipid antibodies, she is mixed connective tissue disease, overlap syndrome, which is scleroderma. She could have a classic hemolytic uremic syndrome, and she could have absolutely nothing of this. Lupus causes thrombotic microangiopathy, full stop. So you can see TMA in lupus patients with all of the other causes of thrombotic microangiopathy negative, and the hypertension in lupus patients, which sometimes get complicated and uncontrolled, also can cause TMA, and you can get necrotizing vasculitis, polyarteritis nodosa type. All of these vascular lesions can happen in a lupus patient. This is lupus vasculitis. This is a nice small arteriole. All of these are immune deposits, globulins, sorry. So this is, we call it uncomplicated. It's the same mechanism as immune complexes deposit in the glomeruli. By the way, they deposit in the tubular interstitium and in tubular basement membranes, and they also deposit in the blood vessels. So you get immune complexes everywhere. Needless to say that these lesions are only seen almost exclusively in class 4, because this is the most class where you get extensive immune complex deposits. Another example of lupus vasculopathy, and this is thrombotic microangiopathy in a globally sclerosed glomerulus. This is a glomerulus which is sclerosed. It's done. And this is the hilar arteriole of the glomerulus, and it's undergoing thrombotic microangiopathy. It has fibrin deposits and endothelial swelling. This is non-inflammatory necrotizing vasculitis, and this was the wall of the artery. All of it is replaced by necrosis. Look at this. These are arteries. these lumps of this very pink material. You can see here is the remnants of the wall, and this is extensive fibrinoid necrosis. This is thrombotic microangiopathy, the classic TMA. Again, thrombotic microangiopathy, a crescent, and extensive TMA and fibrin deposits in a glomerulus. Can we get both? Yes. Are they more common? Yes. So look at this glomerulus. This glomerulus has extensive hyaline thrombi, subendothelial deposits everywhere. This pale pink material are all hyaline thrombi. And this congestion and red cell fragmentation is the thrombotic microangiopathy with the mesangiolitis. So in the same glomerulus, you can also get TMA and evidence of active lupus. And of course, you get extensive arteriosclerosis and you get chronic vascular changes resulting from a previous thrombotic microangiopathy attack or a subclinical attack, which happens in also a good percentage of patients. And these kidneys are not going to do well because they're going to get to be markedly ischemic. Comparisons of renal vascular regions between different classes of lupus glomerulonephritis. Renal vascular regions has no affiliations. They are not like the tubular interstitial lesions. They can be noted within all classes of lupus glomerulonephritis from class 2 to class 5, and you can see they are quite common. Again, the commonest are in 3 and 4, and this is mainly for the acute ones, for the necrotizing lesions, for the thrombotic microangiopathy, and so on. But for vascular lesions as a lump, then you're going to see them all in all classes. And accelerated arteriosclerosis has an impact on increased creatinine, hypertension, and of course, renal survival. This was a female patient who was 14 years old. She presented with hypertension, history of arthralgia, and came vomiting and anorexia. And she presented with progressive rise in serum creatinine. That was the cause of her admission, from 3.5 to 4.7, plus her hypertension. And her investigations showed ANA positive and double-stranded DNA positive. This is the child. She's 14 years old. So 4.7 is really high for her. That's not like adults. Proteinuria, 900 grams. She did not have significant proteinuria. She had significant hematuria. She was markedly anemic. Her C3 and C4 were normal, and they performed a biopsy. And after the biopsy, or second day before the result even was out, they called and said that the patient developed encephalopathy and was in the ICU. So this is a child, female patient, 14 years, who is lupus, diagnosed upon presentation. She had a history of arthralgia. She presented by hypertension, progressive rise in serum creat, 3.5 to 4.7. Her ANA were double-strand DNA were positive. C3 and C4 were normal. Proteinuria 900 grams. Hematuria. They've done biopsy, and then she developed encephalopathy and was in the ICU. What do you think?
وفي ناس كانت باينه TMA ومالجنت hypertension. But I have a question regarding the progressive rise of creatinine. Was it normal before short period before presentation, or it is, or always she has chronic kidney disease? Or the history is unknown?
Yeah, the history is unknown.
Unknown, yes. So if there is anemia and renal failure and calcium and phosphorus and everything, we can have a case of chronic renal failure. And as you mentioned, creatinine 4.7 in a female 14-year-old, this means the very high creatinine. So this may be complications of renal failure. And especially complement is normal. And I'm not sure if you mentioned anti-DNA or it is not, it was not done. الNDNA كان عالي ولا؟
I was asking, it's 900 milligram, not gram. Sorry, it's a typo. It came on the chat. So of course it's not 900 gram. It's
no, I didn't mean proteinuria, because in the very high creatinine
someone asked in the chat, yes.
Who asked?
Someone was commenting on 900 grams.
No, it is known 900 milligram.
Yeah, it's 900 milligrams. It's a typo.
But
Okay.
they put hypertension and convulsion as a case of malignant hypertension, yes.
Okay, guys, I just want to ask a question. Why class 5 with a non-nephrotic proteinuria?
No, I will not select class 5 at all.
No, I'm discussing to the nephrologist who chose class 5. Why class 5? Why class 5 with a patient with renal impairment and non-nephrotic proteinuria?
I think they wrote it by mistake. They mean it is class 6, not 5.
Maybe.
Okay.
Okay, so these are the answers we got. Almost we have an agreement on class on answer D, and which is class 3 and 4 plus associated lesion, and we have few answers probably following E, where they said malignant hypertension and thrombotic microangiopathy. And this was her glomeruli. She had thrombotic microangiopathy, the fibrin thrombi, duplication of the basement membrane, red cell fragmentation. Her tubular interstitium was fine. She wasn't chronic at all. But what was very chronic were her blood vessels. They were in a very bad state. She already had concentric lamination of the blood vessels. She had persistent fibrin thrombi. She had, as I said, extensive mucoid within the walls of the arteries. So she had thrombotic microangiopathy. Only. No lupus glomerulonephritis. So this patient had only thrombotic microangiopathy. So you can get other renal manifestations in lupus. Not always lupus is going to give you only lupus glomerulonephritis or these classes. Your patient is not going only to be class 2, 3, 4, or 5, or 6. You have to think out of the box. Patients can come solely with thrombotic microangiopathy alone, with no evidence of associated lupus glomerulonephritis. And these patients, they do complicate, of course, by uncontrolled hypertension. They get into hypertensive encephalopathy because of the very bad state of their blood vessels. And we're going to discuss this when we come to the TMA. You can have silent lupus nephritis, and this is also common. You see it in your patient, which had been maintained. She's compliant with her treatment. And then all of a sudden, out of the blues, she comes with a creatinine 6 with all markers of chronicity. You take a biopsy or you don't take a biopsy. She is end stage. And you don't know why this happened. The patient did not have any clinical evidence of activity. So this is one scenario. And you get pathological changes without clinical evidence of renal disease. They have been identified up to 1/3 of patients. In some studies, they considered a preclinical phase in the early stage of disease, but in recent studies, we have been seeing it in our practice, is that this happens also with a good percentage of patients who all of a sudden, although they have been maintained for years, develop end-stage renal disease without evidence of any form of activity. And on their biopsies, you find all sorts of things. So lupus can go silent. You can get an ANA negative lupus nephritis. This is in the old era. Now it's rare because the detection, the way we detect anti-nuclear antibodies now are very improved, and they detect any form of ANA negative. But when can you get it negative? You can get it negative and the patient turns positive within 6 months maximum to a year. This is what we see. So if you have a patient with just clinically lupus or a biopsy which is highly suggestive of lupus, and you have a negative serology, just wait and repeat, because these patients do turn positive.
And sometimes we order non-traditional anti-nuclear antibody like anti-Smith,
you should do, of course, ENA. You should do the whole panel of ENA.
Anti-nuclear antibodies, yes.
Extracted nuclear antigens, of course. if you're really suggesting it. And I just want to say that this is common with patients who present with class 5. If the patient first presentation of lupus and lupus glomerulonephritis is with class 5, they're usually negative. And this underlines the importance of further investigating membranous patients with other antibodies and doing phospholipase and so on. So, and that always lupus has to be tested for if the patient age-wise and clinical presentation can fit for lupus, but these patients can be negative up to 1 year, and then they change into positive. It's also common in males. Males usually also, some percentage of males present with autoimmune hemolytic anemia, and then their serology turns positive. And you can have lupus with ANCA positivity, by the way. It's not going to say no. So some patients could have also ANCA vasculitis. And the most recent addition is lupus podocytopathy, minimal change in focal segmental glomerulosclerosis with or without coexisting, usually mild lupus. Now, this entity seems to be a bit confusing. Now, we've discussed podocytopathy. The theory is that the cytokine milieu, which happens within lupus, all the extent of inflammatory cytokines and leukotrienes and all the inflammation which occurs causes podocyte injury. So patients develop a form of podocytopathy, meaning they are going to come with a full-blown nephrotic syndrome, and they can be lupus. What are we going to see in their biopsies? We're going to see minimal change or focal segmental glomerulosclerosis. They can have class 2, 1 or 2 lupus glomerulonephritis, only 1 or 2, nothing else. So you can see some mesangial deposits by immuno or by EM. And then these patients are going to be diagnosed as a minimal change or as FSGS because they have a podocytopathy. You can consider it a secondary minimal change or a secondary FSGS to lupus. This is an entity which exists. It's not common, but it's also not rare. We do see patients in it. Of course, the first thing, especially if the age of the patient fits into a minimal change disease or an FSGS.
How frequent do you see this lupus podocytopathy? Because I assume it is 1 to 2% of lupus.
Yeah, I said it's not rare. It's 1 to 2%.
Okay.
But the important point is, Dr. Hussein, is that when you're faced with the scenario, you need to really validate your lupus serology. So before diagnosing this as a secondary minimal change or FSGS or as a secondary podocytopathy, you need to validate that it's not primary, especially if your patient's age would fit and that this is the first presentation of the patient, not a non-lupus patient who developed a full-blown nephrotic syndrome, for example. So be careful of this entity. As Dr. Hussein mentioned, it's uncommon. And these patients need to be very properly investigated. You need to validate that they are lupus, and you need to validate that this is a lupus podocytopathy in order to administer the proper management.
Moreover, here EM electron microscope is mandatory.
It's very important. But what you're going to see, is you don't have. The problem is that's going to give you minimal change because it's a podocytopathy. You don't have to have. If you have the mesangial deposits, you're probably going to detect it by immuno, and then it's going to solve your problem. But the patients we've seen did not have any coexistent lupus glomerulonephritis, unfortunately. So yes, you need electron microscopy. You will need very proper validation of your lupus profile, repetition, and in a proper lab. Needless to say, we all know how much variable results we get, especially in lupus profile from different labs. Okay, I just need to, just a second. Before we proceed to the changes or the revision of the classification, do we have any questions so far?
دكتورة دولة لو تحب تعلق. ماشي يا دكتور وسام, we can proceed.
So in 2018 came out, before 2018, of course, starting from 2013, there started to be efforts revising what the 2003 classification, validating it, discussing the different subcategorization, what's considered to be valid or not valid. The question in the chat, I'll answer it right now, and so on. So there was a lot of talk that maybe we need another new lupus classification because there were still some gray areas. So in 2018, the Renal Pathology Society, together with the ISN, formed a group of very eminent renal pathologists, and they have started working 2 or 3 years before that, I think from 2015, and it was the first proposal was in 2015 to start revising not only lupus. This is going to follow all the classifications in renal pathology, but step by step, and it's taken by importance. So in 2018, they published this paper in Kidney International. This is not a new classification. This is, as it says,
Dr. Wesam,
revision of the International Society.
Dr. Wesam,
yes.
Can you share the slides, because still here we have the first slide, lupus nephritis. No share.
Really?
Ah, yeah.
Okay. That's strange. Okay.
دكتورة مي.
Let me see.
السلام عليكم.
دكتورة مي, ازي حضرتك؟
اهلا. ازيكم؟
الحمد لله.
ازيك دكتورة مي, منورانا.
الله يخليكي يا وسام، احنا مستمتعين والله.
الله يخليك. طب احنا انا عايزه
شير اول يا دكتورة وسام، لان انت حضرتك هتعملي شير PDF ولا بقى؟ يس
خلاص تمام.
اوكي. اعملي بقى، اعملها
سلايد شو اهي.
اوكي.
سلايد شو
زي الفل، اتفضل.
تمام. Okay, so as I was mentioning, in 2018, this is a revision of the International Society of Nephrology Renal Pathology Society Classification اللي هي in 2003 اللي بقى لنا ساعة بنتكلم عليها. What did the revision include? Clarification of definitions and modified NIH activity and chronicity indices. Full stop. So this is not a new classification yet. All what this paper talks about is clarifying definitions and modification of the NIH activity and chronicity indices and few things in the beginning. This is going to follow the same process like the IgA classification, which I have spent some time discussing in detail when we were discussing IgA nephropathy, because it's going to be done in phases, and every phase is going to follow evidence-based studies. So probably the second phase is going to take, again, we are in 2020 already, and we're still working on the second phase. It's going to still take some time before it's finalized, because everything will need to be properly scored, validated, reproducible criteria, and evidence-based according to the literature and studies performed. So there are no new classifications of lupus. we're still working with the same classification, which is the 2003 classification. We've only, in 2018, there was a proposal for some changes. What are the changes? The first good thing they did was that they have eliminated the subcategories of class 4. We've already done this a couple or 3 years back because it was really useless, confusing, didn't make any sense. And further studies have shown that there is absolutely no difference between class 4S or G. So no more class 4S or 4G. The second thing is that they have removed the letters, which was good as well, because although the classification have added the active and chronic lesions, a lot of people did not understand what does A and C refers to. Plus, there was always a recommendation that we have to continue scoring by the NIH scoring, but some people just stopped the scoring, and this caused the confusion for nephrologists, because most nephrologists all around the world depends on the total NIH score for activity and chronicity for managing their patients. And there was, as Dr. Hussein mentioned, proposal for scoring in all classes of lupus, but this was just a proposal. If someone wants to follow it, fine. I did not see that it has any evidence base yet to go ahead, and we already score the chronic changes. What they did also was, as I said, is that they modified the NIH criteria, and the main modification they did was that they redefined what we call endocapillary proliferation into hypercellularity. So hypercellularity is a better term because it refers to the presence of cells, whether inflammatory cells or endothelial cells. So or it does not actually limit it only to that the endothelium has to be proliferated. So it's endocapillary hypercellularity, including inflammatory cells, which is a more sensitive index for activity. The second thing they did is that they separated neutrophils and added them as a separate sign of activity, which again makes sense because we use neutrophils as evidence of activity in transplantation, for example, and in other glomerulonephritis. So neutrophil is an important cell. So the presence of neutrophils in the glomeruli is evidence of activity. And they have included karyorrhexis with the neutrophils rather than fibrinoid necrosis. So the original indices had fibrinoid necrosis / karyorrhexis. No, it's neutrophils / karyorrhexis. I'll explain what these are. Then hyaline deposits, whether with wide loop lesions, as I said, and or hyaline thrombi, again group, thankfully. Cellular, and they specified that fibrocellular crescents as well in order to prevent confusion, as well as they again regain the interstitial inflammation. And the chronicity score is more or less the same, except that for glomerulosclerosis, they added a total glomerulosclerosis score, meaning it's not only global sclerosis, it's global and segmental sclerosis. So when you're counting the glomerulosclerosis score, the segmental sclerosis also has to be counted because this is a chronic lesion. So we don't only count globally sclerosed glomeruli, but the ones which have segmental sclerosis as well. And they reclarified the definitions for all of these terms. Basically, these 6 glomerular lesions. What we mean by mesangial proliferation, by endocapillary hypercellularity and karyorrhexis, by crescents, by adhesions, synecdoche to the Bowman's capsule, and so on. Cellular and fibrocellular crescents. I'll remind you with the terminology and the definitions in order to understand what we are talking about. I know a lot of you don't understand what is subendothelial deposits, what is wire loops, what is fibrinoid necrosis, and so on. So let me take you through what do we mean by these definitions. What are these lesions? Diffuse is a lesion, as we mentioned before, involving more than 50% of gloms. Focal is a lesion involving less than 50% of glomeruli. Global is a lesion which is going to involve all the glomerulus, while segmental is a lesion which is going to involve less than 50% of the glomerulus. Mesangial hypercellularity means that I have at least 3 mesangial cells in a region in a 3-micron thick section. So if I have a thick section, it's going to appear more cellular. And these nuclei, and this is for pathologists, has to be in clusters, in collection. They cannot be in a file. If they are in a line behind each other, this is not mesangial proliferation. Mesangial proliferation only has to be scored in groups. So they have to be like these 3 nuclei. Otherwise, you do not have mesangial proliferation. This is one of the main reasons why we have a huge problem in the reproducibility of the scoring of mesangial proliferation, and we get a lot of mesangial proliferation in our biopsy reports when really there are no mesangial proliferation in the glomeruli. The second lesion, which was also changed in the revision of the classification, was, as I said, the change of this term endocapillary proliferation into hypercellular. This is what we mean by endocapillary proliferation. As I mentioned before, and I'm mentioning again, this is where you get endothelial cells, mesangial cells, and inflammatory cells all together. Why do we call them endocapillary unit? Because by looking at them, you cannot tell which is which. The end result is that you get a hypercellular glomerulus with an occluded capillary lumen. And so it's better to call it endocapillary hypercellularity, because any form of hypercellularity should be considered activity, not only proliferation. Then extracapillary proliferation or cellular crescents, as you all know them. This is a cellular crescent, and I've added this to show you that crescents does not always appear in crescents. They don't always appear in this perfect crescent shape you see. No, and sometimes it's all what you see of the glomerulus. You don't see a tuft. Again, this is another crescent which is totally circumferential. One of the most important changes, actually, and was the definition of a crescent, when to call a crescent. The original and the traditional classification of a crescent is that it involves more than 25% of the Bowman's capsule and that it has more than 2 layers. Now, this definition has been changed, thankfully. Thank God that it's been changed. And now the correct definition is, or the applicable definition now is that you have less than 10, if you have, 10% or more proliferation of the Bowman's capsule. Just 10%, not 25%, because 10% is significant and it's still a crescent. So if you have 10% and more than 2 cell layer of the Bowman's capsule with extracapillary proliferation, then you need to consider that this is a cellular crescent. What is choriorexis? A very complicated term. Let me remind you with 3rd year medical school, لما كنتوا طلبة في سنة ثالثة, and when you used to take pathology and take necrosis, and we used to give you the pathology of necrosis and tell you that one of the stages of cell death or necrosis is choriorexis. And what's choriorexis? This is presence of apoptotic, pycnotic, and fragmented nuclei. So it's basically nuclear death. Because it was nuclear death, it was always considered to be part of necrosis. But we don't have ischemic necrosis in a disease like lupus nephritis. So choriorexis have been correctly placed with neutrophils, because it's neutrophils actually which die after some time and give us this appearance. This is the same term we use for nuclear dust. And this is how it looks like. You see all of this small, very small black dots. This is the nuclear dust or the choriorexis. This is just to show you, you don't really need to know them. Again, you're not a pathologist. So choriorexis and neutrophils and or neutrophils are considered as an evidence of activity now. Then comes necrosis. This is not your regular necrosis. This is not your regular ischemic necrosis. Ask what do we mean by fibrinoid necrosis? Yes, what we mean by fibrinoid necrosis, I'm going to describe it again or explain it again in vasculitis. But for now, fibrinoid necrosis is a misnomer. It's not true necrosis. It's just excessive fibrin exudation from the walls of the blood vessels and endothelium. And this is what gives you this. And it's a sign of severe endothelial injury. So this is why we consider it an aggressive lesion, and we double score it same as crescents. So this is fibrinoid necrosis. Then these are hyaline thrombi. And as I said, subendothelial deposits, hyaline thrombi and wire loops are the same lesion. What happens simply is you get extensive deposits on the glomerular basement membrane, subendothelially, and they get to be numerous and a lot for the basement membrane. So they start leaking into the capillaries inside, into the capillary lumen. And they start taking a shape of the capillary lumen and be rounded and eventually occlude the capillary lumen. So this is why we call them pseudo-thrombi, and they're only hyaline thrombi because they are immune complexes. They are not a true thrombus. They have no red blood cells, no white blood cells, no fibrin, no platelets, nothing. These are just excessive immune complex deposits, including the capillary lumina. And if they get to be a lot, they cause rigid capillary basement membranes, giving us what we call hyaline thrombi. Now, this is a very nice wire loop, and this is what we call wire loop. I hope that you can all see it. Again, this is what is known as wire loop. Again, this is wire loop, and you see the rest of the glomerulus have endocapillary hypercellularity, subendothelial deposits here again. So when the basement membrane gets rounded and rigid, they call it a wire loop. And this is what I was just saying, you get extensive deposits and they start leaking into the capillary lumina. This is not pathognomonic of lupus. So please, this is suggestive of lupus, highly suggestive of lupus, not pathognomonic. And actually, there is nothing pathognomonic of lupus. There is not a single lesion you can look at and say, oh, this is lupus glomerulonephritis. No. Cryoglobulins, for example, gives you exactly an identical picture of this glomerulus. So this is, so you just would know that you don't read wire loop and then you go berserk and you say, well, the biopsy said that this is lupus glomerulonephritis. No. Again, classic wire loop.
So what's your opinion regarding renal limited lupus nephritis? The term renal limited.
You mean with the ones with the seronegative?
Because this, yes, there is nothing in the serum, nothing in creatinine. It's just pathology lupus nephritis, and they say it is renal limited. Do you agree about this term?
No, because you cannot diagnose lupus by biopsy.
Okay.
Unfortunately. You can diagnose other things, but not lupus. You can say if you are
probable.
Highly suggested. I can say, yes, this is 90% lupus. It has to turn positive one day for the serology. But no, I don't believe that there is anything called renal. It's against the concept of lupus, basically.
Okay.
Okay. So again, this is wire looping, and you have this hyaline thrombus. And a comment on what you said, Dr. Hussein, we overdiagnose lupus and we miss it. Both scenarios happen. So please, for all the young ones, stick to the criteria of diagnosis in order not to miss it or not to overdiagnose it. This is typically endocapillary hypercellularity. This is a very high power. I'm showing you only part of the capillary lumen, which is full of cells. inflammatory cells, endothelial cells, and all type of cells to give you just an idea what is this endocapillary hypercellularity. And now this is the crescent, and you can see this crescent was involving only 10% of the glomerulus. Here it is, but this is a crescent, and this is part of the glomerulus with endocapillary hypercellularity again, and there is nothing else. And this was also comes from a lupus patient. Again, fibrinoid necrosis. It doesn't stain in PES, so you get this light pink patch, and you see here some inflammation. And look at this, and I brought this to show you how crescents develop, that usually you get rupture of the glomerular capillary basement membranes with all the inflammation, leukocytes inside. Remember what we discussed in the patterns when we were discussing patterns of glomerular, and that how a proliferative glomerulonephritis can give you always fibrinoid necrosis and crescents, whatever the underlying mechanism. This is the example of it. And you can see a lot of hypercellularity and fibrinoid necrosis, and all of these inflammatory cells, rupture of the glomerular basement membrane, leaking into the Bowman's capsule, irritation of the porocytes outside, and an early crescent is starting to form. Okay, now this was a 30-year-old female who was diagnosed clinically and by investigations as having lupus. She's lupus. She also had a family history of lupus. Her brother died on renal replacement therapy, but never took a biopsy. She presented with a proteinuria 2.4 grams, slightly consumed C3 and C4, and her serum creat was 0.5. Okay, she was class 4, as you can see. But she only had subendothelial deposits and endocapillary hypercellularity. And yes, lupus patients usually comes with a minimal renal impairment or normal renal impairment. A lupus patient which comes with acute renal failure has something else going on other than lupus activity. So usually lupus activity is not going to get you into renal failure. Patients have to have something else going on with them, usually an associated vascular disease. So this patient had class 4. Her immuno showed again IgG and IgA and C3, and she had a class 4 with a mild activity, no fibrinoid necrosis, no crescents, nothing, no chronicity index, only 1. So only subendothelial deposits, some neutrophils, and some hypercellularity. She was put on steroids. She marked improvement of the proteinuria, and the steroids were eventually tapered to a minimal maintenance dose. Her follow-up was satisfactory, apart from she kept coming with repeated episodes of severe abdominal pain, and she had appendectomy and 1 abdominal exploration for query intestinal obstruction, upon which they removed the appendix, and no one could explain why she has this constant abdominal pain. 6 years after the first biopsy, she developed rather rapidly massive edema and was found to have a proteinuria of 8 grams with still normal serum creatinine. A second biopsy was done. And at this time, I have no idea about the serology. They did not tell me. So I don't know whether she had consumed complement or not, but I assume no. So what do you think? So now she came with, again, normal function, but she was markedly proteinuric. She was nephrotic almost. And she had, I remember now, she had normal C3 and C4 that you were not consumed.
So here is some answers. Class 5, amyloid.
The obvious answer is going to be class 5. Amyloid, interesting. So E, an interesting diagnosis. Okay, and they are right. She had amyloidosis, and her amyloid was secondary, and she turned to have FMF, and that was the reason behind her repetitive abdominal attacks. So, message: in lupus transplant, it is indicated to repeat biopsy whenever something in the clinical picture does not fit. Just coming with Progressive proteinuria, where she's supposed to be an absolutely no activity with a query clinical history of abdominal obstruction, and we don't know what's going on. Association with other pathologies can occur in well-established cases of lupus. So it does not mean that if the patient has lupus, she's not going to develop other renal disease. Patients get necrotizing post-immune ANCA-negative vasculitis, they get crescentic GN, they get interstitial nephritis out of proportion with glomerular changes, they get amyloidosis, they get diabetic nephropathy, by the way, from the steroids, they can have thin basement membrane disease, and most important, they get hypertensive nephrosclerosis and get complicated by uncontrolled hypertension. It's not always lupus. So also consider this. Not because she's a lupus patient, we will always see lupus. So the role of pathology or the biopsy in a lupus is to put the case in a certain class to try to assess activity and chronicity. Maybe confirm the diagnosis if we can. Maybe unmask undiagnosed cases if we can. I can alert you and tell you this patient is probably lupus. Go and repeat her serology. Is to diagnose associated conditions. I can suggest pathogenic mechanisms. Maybe she has infection, maybe she has APL, antiphospholipid syndrome, maybe she has scleroderma, or he. And to evaluate recurrence in grafts. This is a long list of things to do, but it's not to diagnose SLE. I hope this is clear. You don't take...
It is clear, and I can add here an investigational and debatable issue is to monitor remission of treatment by repeated biopsies to confirm histological remission, because usually we find disconcordance between clinical and pathological activities. Sometimes the patient is clinically very active and the pathology is quiescent, and vice versa.
Yes.
And I would like to hear from you about this point, clinical pathological correlation.
Well, this is beyond the scale of this lecture, of course,
Yes.
but for example, this is one of the reasons why protocol biopsies have been proposed in lupus, like transplant. And I always see the similarity between lupus and transplant patients, like transplant rejection. So yes, the reason why there is sometimes you get disproportion could be a long list. One of them is that you don't have an adequate biopsy to start with. The number of glomeruli, again, lupus is like FSGS. For proper classification, scoring, and recognition of any hidden lesion you don't see, you get the TMA in a single arteriole. You need at least 20 glomeruli. Don't get a biopsy of 8 glomeruli and then wonder why it does not fit with your clinical picture. So this is number one, and this is the commonest cause why you have a discrepancy between the clinical manifestation and the pathology. But other times, as I always say, lupus is a systemic disease. So not always the activity is targeting the kidney. You also need to consider this. Maybe patients are active, but the activity is not focused on the kidney. They could have other active lesions in other organs. And the other way around, as we mentioned, like silent lupus. Patients can go activity in their kidneys while clinically you don't see anything. So you do have a subclinical lupus.
I agree with you, Professor Wesam, and moreover, I got the sense that lupus even is different from country to country. The behavior of
Yes,
lupus
I definitely agree.
is completely different in Egypt than the Western communities.
Than the Western communities, definitely. This is a fact, and that's why I don't count so much on all the published literature, because we do have a different profile in our patients. And to answer your question, when lupus glomerulonephritis cannot be classified accurately, when the pathologist can't give you a specific class. As I said, number one is sampling, specimen adequacy, cortex medulla, focal, and diffuse, because you can miss a class 3 easily. A single active glomerulus is a class 3. only in one glomerulus. And this we see. This is not rare at all. This happens. Prior treatment, how many biopsies are taken when already the patient is treated? Then you want proper classifications. Treatment alters pathological changes. So when you give aggressive treatment, like steroid shots or endoxin to the patients, and then you want to biopsy for proper classification, no, you're not going to get a proper classification. And the problem with lupus and other vasculitis, but lupus in specific, is that usually patients, what you see in the kidneys are build-up process. You have long-standing lesions and new lesions on top of them. So it's not always a straightforward process. Sampling is very, very important because a lot of people ignore it. For example, this patient, she's 40 years old, she's long-standing lupus, 20 years, her first presentation with class 4. This is typically the scenarios we're talking about. Patient was stable, then she presented with a progressive rise of serum creatinine over 1 month. She was 1.8, then over 1 month, her serum creatinine became 3, and she is on steroids and MMF. Now her biopsy showed 6 glomeruli, 1 of them globally sclerosed, so we have 5. And 2 of the 5 showed segmental tuft sclerosis, and the rest showed mild mesangial proliferation. Is this an adequate biopsy? Do you think we should apply a class for this biopsy? If you want to apply a class for this biopsy, it's going to come up with class 2. And exactly as you said, would class 2 fit into a patient, a lupus patient, presenting with a progressive rise of serum creatinine?
No. No.
Exactly. And not even a chronic lesion would fit. So simply, this is an inadequate biopsy. And you have to learn when to admit that this is an inadequate biopsy and not to base any conclusions on this inadequate biopsy. I once was in a meeting, I think Dr. May was with me, and you were there as well, when they also said that the patient was all through lupus, but only the biopsy was against lupus. Why was the biopsy against lupus? But because the biopsy had globally sclerosed glomeruli and had no immune deposits in it, and it was also a 5 glomerular biopsy. So be careful. Read your biopsies well and your reports well, and don't build conclusions on weak evidence like this. This is a biopsy which is absolutely useless, and you need to repeat it. Finally, transplant. We know that most lupus patients will develop end-stage renal disease, and transplantation is, of course, generally well tolerated with few controversial reports about the recurrence of lupus. What is agreed upon, or the consensus, that if lupus returns, then it's going to be only class 2. There are some reports that it has, it's a risk factor of graft loss, but there are other reports that it says that it has limited impact on the patient survival. Usually patients which might be complicated are the ones who has other diseases than lupus, like associated antiphospholipid syndrome. And finally, is it the last new classification? I don't think so. We will always keep classifying lupus. As I said, this is an ongoing story. Thank you very much.
شكرا جزيلا دكتور وسام، يعني بصراحة حاجة يعني فوق الوصف يعني. If there is any question, I think everything is clear. Do you have question حديدي؟
المحاضرة كانت كريستال كلير وممتازة كالعادة طبعا. فبشكر الدكتور وسام جدا. شكرا.
So at the end of this presentation, we are sorry for the beginning because there was technical problem. احنا عندنا الدكتورة نهلة. الدكتورة نهلة عاوزة تسأل ولا بتسقف؟ احنا خلاص احنا يعني بشكرك دكتور عمرو السيد، اتفضل. دكتور عمرو. خلاص اوكي. انا هنختم بقى، يعني بنشكر حضرتك شكرا جزيلا دكتور وسام. totally appreciating your efforts, your sincerity and your meticulous presentations. يعني خليتي كل النفرولوجيست يعني حاسين بالباثولوجي. شكرا جزيلا. وان شاء الله يعني على موعد مع الدكتور وسام يوم السبت الساعه 3 العصر، لان الجمعه عندها ارتباطات، فيوم السبت ان شاء الله نلتقي الساعه 3 مع الدكتور وسام. شكرا جزيلا
ان شاء الله.
مع الف سلامه.
الله يحفظك.
وبشكركم جميعا. تصبحوا على خير. مع الف سلامه.